Hello and welcome to today's webinar, Where There's Smoke, There's Fire, E-Cigarette or Vaping Associated Lung Injury. My name is David and I'll be in the background answering any WebEx technical questions. If you experience technical difficulty at any time during this WebEx event, please submit your technical issue in the Q&A panel and I will assist you. Please note that as an attendee, you're part of a larger audience today. However, due to privacy concerns, the attendee list is not displayed. All attendees will be in a listen-only mode for the duration of today's call, and as a reminder, this call is being recorded. Time permitting, we'll be holding a Q&A session at the conclusion of today's presentation. We encourage you to submit written questions at any time during the presentation using the Q&A panel at the bottom right of your screen. Please type your questions into the text field and hit send. Please keep the drop down as all panelists. With that, we invite you to sit back, relax, and enjoy today's presentation. I would now like to introduce your first speaker for today, Gretchen Brummel. Gretchen, you now have the floor.
Thank you, David. Welcome everyone to our January CE offering, Where There's Smoke, There's Fire, E-Cigarette or Vaping Associated Lung Injury. My name is Gretchen Brummel and I will serve as your moderator for today's session. We also want to make you aware of two upcoming educational opportunities in February and March regarding reimbursement and ambulatory pharmacy. Please join us for these sessions as well. To reiterate some of the information David had shared, we are recording this presentation and it is in listen-only mode. I encourage you to submit your questions throughout the presentation in the Q&A box in the lower right-hand corner of your screen. We will distribute the slides following the event, and the recording will be available a few days following the webinar. Lastly, you will receive an email sharing how to claim CE credit for this event after the presentation. For additional Vizient-supported resources and educational opportunities, please visit our website at vizientinc.com/pharmacy solutions. So without further delay, I'd like to introduce our speakers for today. Dr. Ryan Feldman is an emergency medicine clinical pharmacist at Froedtert, a clinical consulting toxicologist with the Wisconsin Poison Center, and assistant professor at the Medical College of Wisconsin School of Pharmacy. Ryan received his PharmD at the University of Wisconsin-Madison and completed both his PGY1 in pharmacy and PGY2 in emergency medicine at Froedtert. He has recently published on the topic of inhalation injury. Dr. Matthew Stanton currently practices in emergency medicine at Froedtert, is a consultant with the Wisconsin Poison Center, and is an assistant professor at the Medical College of Wisconsin School of Pharmacy. Matthew received his BS in bacteriology from the University of Wisconsin-Madison and his PharmD from Midwestern University. He subsequently completed a PGY1 at Froedtert Hospital. Both of our speakers precept pharmacy students and residents at Froedtert Hospital and the Wisconsin Poison Center. Additionally, they administer didactic sessions to pharmacy and medical students, residents, and fellows on emergency medicine and toxicology topics. With that, I'd like to thank our speakers for their contributions, and I will yield the floor for their presentation. Thank you.
Thanks so much, Gretchen. We're really excited to get to talk with everyone about what I think is a really interesting topic. I know this has certainly gotten a lot of media attention and raised a lot of questions for healthcare providers, especially in the ER where I work, when you get a young person with flu-like symptoms who's used a vape. I know Matt and I both had the opportunity to consult on some of these cases through our role at the Poison Center. And I actually remember my first consult talking with somebody about a young patient with a severe pulmonary injury back in July, and lots of questions surrounding what could cause this, what's the likelihood they'll get better, what treatments can we do. And unfortunately, we don't have a ton of new information, but it's been really amazing watching this whole thing evolve in front of us and watching the CDC's response to the outbreak and all the health department and public health come together to try to tackle this. So without further ado, I'd like to jump into the actual presentation. We have nothing to disclose in regards to this presentation. Neither Matt nor I are current e-cigarette users. And in terms of objectives, we want to describe the history of vape-related health concerns briefly, and then we'll jump into EVALI itself. We'll explain the role that vitamin E acetate has played in this outbreak and try to suss out a little bit more about that. And then we'll summarize CDC treatment recommendations in case anybody encounters an EVALI patient and talk about where you can find resources for that. Finally, we also want to discuss products that have been associated with EVALI. I know a lot of people have been getting questions. what is safe, what is not. And unfortunately, there are still many questions left to be answered, but I think at the point of this outbreak now, we're starting to figure out what questions we do need to have answered. And I'm sure we'll get lots of good questions throughout the presentation, so looking forward to discuss that as well. And lastly, along the way, we're going to summarize the 30-something publications that have come out since we were asked to do this webinar. So it's been really fun to stay up to date each day and each week, updating our slides with all the new information coming out. So let's start with Dan. Dan is a 23-year-old male who presents to clinic for cough, chest pain, nausea, and fever for one day. His roommate was recently diagnosed with influenza, but he has no other sick contacts, no past medical history, but he does admit that he is a cigarette smoker and an e-cigarette user. This raises a lot of questions in the setting of an EVALI outbreak. Does Dan have EVALI? Should Dan be admitted to a hospital and treated for this? Should we do any imaging beforehand? And if he doesn't go to the hospital, or even if he does, what should we treat him with? We are going to dive into all those questions, but for the first half of this webinar, we're actually going to focus more on what caused this whole problem in the first place. So just to keep everyone on the same page, we'll do some definitions. Vaping is considered the use of any electronic cigarette. So you might hear me say vaping or e-cig, talking about the same thing. I think most people are familiar with THC and CBD. THC is the psychoactive component of marijuana. CBD is a non-psychoactive component of marijuana or cannabis that a lot of people like to put in vape pens and vape. And then BAL, or bronchoalveolar lavage, this is just a sample of lung fluid that we can take from patients and do tests on. And we do talk a fair amount about it, so I wanted to define it here. A little history about e-cigarettes. They were invented in 2003 by a Chinese pharmacist named Han Lick. The first generation e-cigarette was a battery with an atomizer that heated a cartridge and vaporized the fluid in that cartridge so you can inhale it. The fluid was generally glycerol or propylene glycol with nicotine. And every iteration of an e-cigarette after that has generally had the same structure. We have a cartridge with a liquid of our desired additive, be that nicotine, THC, CBD, or flavoring. We have an atomizer that heats up that liquid and a battery that powers the atomizer. We have a variety of different shapes and sizes that come in. You can have a pen, a USB style e-cig, you could have e-pipes, cigars, e-hookahs, tanks, mods, rechargeables, you name it. It came to the US market in 2007 and were aggressively marketed. By 2014, it was the most commonly used youth tobacco product and was being used amongst smokers and non-smokers alike, likely due to the perceived low adverse health effects of inhaling vapor compared to actual smoke from combustion. If we look at a 20-year trend of the 1-month prevalence of cigarette use amongst 8th, 10th, and 12th graders, we can see that it's been declining significantly from 27% down to 4.6%. E-cigarettes, however, have been on a pretty meteoric rise amongst high schoolers. And in 2019, it was estimated that roughly 1/4 of high school students have used an e-cigarette, and some 5 million youth were current e-cigarette users. When this sort of disruptive technology came to market, there was actually a variety of initial health concerns. So one was exploding batteries. Sometimes you could be using the e-cigarette and it would blow up in your face, or it would sit in your pocket and explode. So we started to see burns of the face and thighs where e-cigarettes were being kept. We also saw increases in nicotine liquid overdoses. For reference, one cigarette contains about 10 milligrams of orally bioavailable nicotine, as some of the e-liquids that you need to use to fill these vaporizers can contain up to 100 milligrams per mil. And with pediatric fatalities as little as 50 milligrams, that would be 5 cigarettes or half a milliliter of solution. So certainly concerning if it gets in the hands of a kiddo. And we have seen an increase in e-cigarette and liquid nicotine overdoses, or sorry, exposures reported to U.S. poison centers over the last few years. Then we started seeing diseases that we normally associate with cigarette smoking pop up, things like acute eosinophilic pneumonia, or something called respiratory bronchiolitis, interstitial lung disease. And then we saw diseases that we normally associate with chemical exposure show up in e-cigarette users. So one example is bronchiolitis obliterans. This is actually called popcorn worker's lung, because it was found in popcorn workers and it was thought to be associated with a chemical called diacetyl, which is a compound in buttered popcorn flavoring. And while they have found diacetyl in e-cigarettes, it's usually at levels that are lower than those of regular cigarettes. Other things like giant cell interstitial pneumonia, this is also called hard metal pneumoconiosis or hard metal lung disease, and it's associated with cobalt exposure. And there have been cases of finding heavy metals like cobalt in the vapor of e-cigs that are possibly getting pulled through from the atomizers. And additionally, other diseases like lipoid pneumonia, which is associated with chronic lipid aspiration, have been reported. So all these funky chemical exposure diseases has led to a lot of scrutiny under what exactly is in the liquids and the vapors of these e-cigs. So while yes, they do contain the listed ingredients, being glycerol, propylene glycol, or nicotine, when we look at the liquids, we also find things like acetone, ethylene glycol, formaldehyde, and in the vapors, acrylamide, heavy metals, and toluene. So yes, there are potentially toxic compounds that have been found in liquids and aerosols of e-cigs, but when you do the head-to-head analysis, they're generally lower than those found in cigarette smoke. So the general mentality that e-cigarettes are less damaging than cigarettes, but more damaging than nothing at all, was somewhat widely adopted amongst a lot of the medical community and general society. Then, in August 1st, 2019, some 12 years after the introduction of e-cigarettes to the market, the Wisconsin Department of Health alerted the CDC regarding a cluster of severe lung injuries in primarily young patients with no other identifiable cause of disease, except the only unifying risk factor was they had all used a vape within the last 90 days. The CDC then began syndromic surveillance and asked states to begin reporting to them other patients who have similar symptoms. So this was the rise of e-cigarette or vape-associated lung injury, and this was the first indicator that led the CDC to start collecting data. So what exactly is EVALI? Well, it's a syndrome, which means it's a constellation of symptoms. Those symptoms could be respiratory, gastrointestinal, or constitutional. For respiratory symptoms, we see things like shortness of breath, chest pain, cough, frequently with pulmonary radiographic findings. In the largest case series, the Wisconsin-Illinois case series, 91% had positive X-ray findings, and 100% of those who went under CT had positive CT findings. But we also see things like gastrointestinal symptoms of nausea, vomiting, diarrhea, as well as fevers and weight loss. Now, if you're thinking about all these symptoms, you might think this sounds indistinguishable from influenza, and you'd be correct. The main difference is that to have EVALI, you have to have no other identifiable cause of your symptoms, meaning infection has been ruled out with appropriate labs, and there's no rheumatic, malignant, or cardiac cause of your symptoms. And additionally, you must have the unifying risk factor of use of a vape within the last 90 days. Now, the mix of symptoms that you'll see, it'll vary depending on what case series you look at, but generally, you're actually going to see a mix of all of them together. So even though it's called e-cigarette and vape-associated lung injury, in one analysis of outpatient EVALI patients, only 9% presented with just respiratory symptoms. So you're very likely to see both gastrointestinal and constitutional symptoms. The clinical course of EVALI can develop over days to weeks, and unfortunately, it frequently requires high levels of care. So intubation is very common, ECMO has been reported, and lung transplant. So this is a very severe disease in those that it can manifest in. The mortality rate is somewhere near 2.1%, which is alarming because this affects primarily younger patients. So the CDC has some definitions for what they call a confirmed case of EVALI for reporting and a probable case. You can read through all the different criteria there, but the long and short is that a confirmed case of EVALI is someone who has used a vape, has symptoms, and no other plausible diagnosis, as well as all the appropriate labs sent to rule out other diseases that could cause their symptoms. A probable case is a vape user who might have a co-infection or perhaps did not have all the appropriate labs sent to rule out other diseases that might confound, but the treating team still believes it could be EVALI. And using those case definitions, as of January 7th, 2020, some 2,600 patients have been hospitalized to EVALI from 50 different states, the District of Columbia, Puerto Rico, and the U.S. Virgin Islands. And this is primarily a U.S. and North American problem. There are very few cases of this reported outside of the U.S. If they are, they're frequently associated with travelers using U.S. products. And we have seen 57 deaths from geographically diverse regions, 27 different states and D.C. Fortunately, peak reporting happened in September of 2019. However, there's still cases under investigation and reporting is trickling in, so it's not completely gone. So it is important to be able to recognize and treat this disease should you encounter it. The EVALI patient themselves is generally a male, 67% of which being so, and the vaping patterns are pretty varied. 80% report vaping some form of THC, and 13% report only nicotine, 1% report CBD only, and 5% report no CBD, THC, or nicotine products. So more likely flavoring or some other substance. Their age is generally, they're younger, 24 years old, and 95% of these patients are becoming hospitalized with up to a third requiring intensive care. So it's a pretty severe burden of disease. And because of that, the CDC mobilized an emergency response team that was not only collecting surveillance on reported patients, but also trying to search for the cause. So they started testing products that were submitted from EVALI patients. They tested both vape products and the aerosols from the vapes. And they tested lung fluid samples, which are those bronchoalveolar lavages that we talked about. And what they were testing for are called priority toxicants, or things that they deemed were likely to cause this syndrome. So we see things like vitamin E acetate, and then a whole bunch of very long words, plant oils, medium chain triglycerides, coconut oil, petroleum distillates, and dilute terpenes. Generally, we classify those compounds as hydrocarbons, which have a well-characterized history of causing pulmonary injury if they're inhaled or aspirated. Vitamin E acetate's history with toxicity in the lungs is a little foggier. So I think it's a good time to dive a little bit deeper into what vitamin E acetate is and how it might be implicated in this outbreak. Vitamin E itself is also known as tocopherol. And there's a bunch of different types of tocopherol, alpha, beta, gamma, delta. But the ones that we are worried about, or the ones that we usually are exposed to, are alpha and gamma. And those are the ones that we see in our foods. And alpha tocopherol is the one that we're talking about in regards to the EVALI outbreak. This is the one that's been found in most products and lungs. We also see vitamin E in dietary supplements and cosmetic products, and more recently in e-cigarettes or vaping products used as a diluent. So it's thought that this kind of thick, oily vitamin E acetate is used to dilute out your more expensive THC oil, at which point you can make your product last longer. In terms of toxicity, it's not usually toxic when applied to the skin or ingested orally as one of our supplements or in food. So what exactly is the toxicity of vitamin E acetate? The long and short is we're not sure. But the reason you keep hearing everyone say vitamin E acetate and not vitamin E is because we're not sure if it's the acetate or the vitamin E. The molecule itself is one molecule of acetate linked to the molecule of vitamin E via an ester. And the mechanism of toxicity, there's some theories. One might be that this long aliphatic chain on the end of it interferes with pulmonary surfactant, and that's the liquid in our lungs that helps us exchange gas. Another thought is that acetate, when it goes under vaporization, can turn into ketene. Ketene actually has a pretty good history of causing pulmonary injury, and it can act similar to phosgene gas and cause delayed pulmonary edema. The CDC is currently attempting to quantify ketene levels in EVALI patients' lungs, but we don't have any current data, and these theories around toxicity are exactly that, just theories. We don't have a lot of experimental data to support it, and the animal data is even more confusing. Some data actually suggests that alpha tocopherol, the one we've been finding in lungs and vape products, actually reduces neutrophil recruitment and prevents airway hyperreactivity. some epidemiologists think that if there's not enough alpha tocopherol in food in regions, it actually leads to increases in asthma there. Other data shows that gamma tocopherol increases neutrophil recruitment and negates the alpha effect. And there's data that supports that gamma tocopherol is actually protective in sheep models of lung injury. But if we look back at that molecule, gamma tocopherol also has this long side chain. So if that is what's interfering with surfactant, it's not clear why it wouldn't do so in sheep. And lastly, the only real or readily available data regarding the toxicity of vitamin E acetate in the lungs was in rats fed massive doses of alpha tocopherol acetate for about 13 weeks. And while there was rat lung inflammation, there was also multiple organ dysfunction and kind of coagulopathy. So it's not necessarily extrapolatable to the current outbreak of how people are being exposed. Nonetheless, in November of 2019, the CDC managed to get a hold of 29 lung fluid samples from 10 different states. Each and every one of those lung fluid samples tested positive for alpha tocopherol acetate. None of the other screened priority toxicants were present. So it appeared that vitamin E acetate was associated with the EVALI BAL, and we were finding vitamin E acetate present in the EVALI lung. To strengthen that association, they managed to get a hold of a total of 51 BAL samples, and they tested them all for vitamin E acetate. 94.1% were positive for vitamin E acetate. I might call vitamin E acetate VEA as we're going throughout this presentation just because I have to say it so many times, so sorry if I interchange it a little bit here. They then compared that to 99 healthy individuals from the last 3 years. So this was composed of 10% from the year of 2019, the year of the current outbreak, and it also had 52 never smokers, 29 smokers, and 18 e-cigarette only users. So a good broad demographic. And they found that 0% had vitamin E acetate in their lungs. So it appears that VEA is absent in the healthy lung, but was present in EVALI lungs. In the meantime, Minnesota began testing products that they had seized during raids of illegal vape distributors. They tested both e-liquids as well as the vaporizers for vitamin E acetate and medium chain triglycerides. And what they found was that there was no vitamin E acetate in any of the vape or e-liquids. There was some medium chain triglycerides in the vapes, which gives a little bit of rationale to MCT possibly not being a culprit, because we might have seen this happen earlier if that was the case, since it was in 2018 products. Then they looked at 2019 vapes that were seized during raids of illegal distributors, and they found that every one of those vape products tested positive for vitamin E acetate. So it appeared that vitamin E acetate was absent in the 2018 product, but present in the 2019 product during the time of the outbreak. Next, they tested products submitted by patients who had EVALI. When they tested their THC products, they found that 11 of the 12 were able to provide at least one product with vitamin E acetate in it. And the one patient that didn't actually submit all their products, and they admittedly used multiple THC-containing products. So it's possible that maybe they did have one, it just wasn't tested. They then tested all of their nicotine products from 8 of the EVALI patients, and 0 of 21 tested positive for vitamin E acetate. So it appeared that vitamin E acetate was present in at least one THC product owned by an EVALI patient, but absent in any of the nicotine products that they could find and test. And if we look at testing to date, as of January 8th, the FDA and CDC have tested nearly 800 products, around 60% of which contain THC, and 50% of the THC products contain vitamin E acetate. And there's no mention of any nicotine products containing vitamin E acetate. They don't explicitly say that they don't, but you would think they would report that if that was an issue. And so it looks like THC products are associated with VEA, and VEA is associated with EVALI. So what kind of products are the patients using that are showing up positive? Well, if we look at the demographics of hospitalized EVALI patients, over 152 different brands of THC products have been reported. There are some trends. Dank vapes is the most commonly reported brand overall, composing 56%. Then other categories like Rove, TKO, and Smart Cart are the next most commonly reported. There is a little bit of regional variation, so Dank Vapes is the most commonly used in the Northeast and the South. Rove is the most commonly used in the Midwest, and TKO and Smart Cart are the most commonly used products in the West. Now, these are just products they're reporting using. They could also report that they had eggs for breakfast, and it doesn't mean that it was the cause of disease. But if we look at the products that were tested by Minnesota from EVALI patients, we see some familiar names. Dank Vapes, Rove, and TKO extract were all products that tested positive for vitamin E acetate. So it does appear that VEA-confirmed products are the most commonly reported with e-cigarette or vape-associated lung injury. So have we found the cause? The CDC found this vitamin E acetate, and it's being contaminated into THC devices, and this is the cause of 100% of the disease. The media definitely took hold of this and ran with it, and there was a lot of frenzy and excitement around vitamin E acetate. But when you look at the actual vaping patterns, we see that only 80% report using THC. 13% report using nicotine, 1% CBD, and 5% none of those. So what is causing disease in these patients? Some have said, well, it's just underreporting. Actually, everyone's using THC and they're not telling us. And that is absolutely true that underreporting is happening. For instance, in those 51 BAL samples, only 75% reported using THC, but 85% were positive. And that said, it's not 100% underreporting. I'm sorry I don't have a slide for this, but there was a recently published analysis of nicotine-only users that have EVALI out of Illinois. And essentially, 17 patients stated that they used only nicotine, and after further investigation, about half of them either tested positive for THC or later reported using THC. But 9 of the patients were THC negative on toxicology screen and reported using no THC, and about 50% of those patients were still in the ICU for EVALI-related symptoms. Now, it is worth noting that those cases were deemed as probable EVALI. So it is possible that it's a combination of underreporting and over-including patients or misdiagnosing them as probable EVALI instead of some other disease that is causing their symptoms. But it's also entirely possible that we've missed the ball overall and there's another toxicant causing disease. So if you actually look at the cellular injury levels of EVALI, we see 4 distinct types: lipoid pneumonia, diffuse alveolar damage, acute fibrinous pneumonia, and organizing pneumonia, which suggests that there's multiple possible etiologies leading to the same symptoms. And vitamin E acetate itself, is this really a toxin, or is it simply correlated with exposure? One set of criteria that we can use to help determine what is associated with disease versus what is causing disease is called the Bradford-Hill criteria. It's pretty long, and there's a couple of different facets. We're not going to spend too much time on it. But if we apply these criteria to vitamin E acetate, I think we'll see that there's more questions that need answering before we can really point a finger. So if we look at the strength of association, the stronger the relationship, the more likely that that value or that exposure is related to disease. We've only tested a small percent of products and patients. However, the majority of who we do test are positive. In terms of timing, meaning that the cause should precede the effect, well, we didn't see vitamin E acetate in 2018 products, but we did see it in 2019 when this outbreak occurred. And theoretical plausibility, is there a rational explanation for how this could be causing disease? Well, maybe ketene production or surfactant, maybe inflammation, but we're lacking a lot of data to support these theories, but at least it logically makes sense. In terms of our other factors, consistency, meaning multiple observations of an association with different people under different circumstances. Well, we found EVALI in THC, or we found vitamin E in EVALI THC products. We found it in 94% of EVALI BALs, and we did not find it in any healthy lung, but we also haven't found it in non-THC products, which raises the question as to what's causing it there. In terms of coherence, does the cause and effect correlate with our known literature that supports the toxicity? Well, animal data is relatively conflicting on the toxicity of vitamin E acetate and sparse. And as far as only one cause leading to one effect, 0% of tested nicotine products have been reported to have vitamin E acetate, yet nicotine-only users are still being affected per the reporting that we have. So is it possible that multiple exposures are causing the same syndrome? And finally, experimental data should support our grounds that we believe this substance is toxic. However, there are very few studies, and the ones that we do have are conflicting. So in the end, EVALI is a syndrome. It's entirely possible that multiple agents may create similar symptoms, just like flu and pneumonia can both cause fever and shortness of breath. Vitamin E acetate may be a marker of other toxicant exposure, or it might be one of numerous chemicals that are causing EVALI. We're left with some known knowns. We know that vitamin E acetate is associated with the EVALI BAL, and we know that it's associated with unregulated THC products like dank vapes, TKO, or Rove. But unfortunately, we have more known unknowns. Is vitamin E acetate culprit or correlate? I think further toxicity studies and animal data will help shine a light onto what the actual toxicity of vitamin E acetate is, or if it's just a correlate with some other toxicant that might be linked to all the cases. And what is associated with non-vitamin E acetate EVALI at this point? Is there a safe product out there, or will VAE or some other toxin start appearing in products after more testing? And more questions, who is responsible? The state of New York did subpoena 3 companies who had vitamin E acetate listed as a diluent in some of their products that they were selling. And there have been some large busts in the state of Wisconsin of illicit dealers of vapes. So maybe it's all illicit, maybe it's actual trade contamination from companies selling vitamin E acetate. But more questions are, will this happen again? This is not the first time that we've had an outbreak of severe disease related to unregulated substances. There was a recent outbreak of coagulopathy due to synthetic marijuana contaminated with long-acting anticoagulant rodenticides. It is not clear what regulations are going to help or hurt. Will that increase black market supply? We don't know. So in this scenario with all these swirling questions, what's a vapor to do? Well, since no product is known to be safe, the CDC recommends that all e-cigarette or vaping products be avoided. If your patient is using an e-cigarette or vaping product to quit smoking, now is probably a good time to talk with them about using FDA-approved nicotine replacement therapies as opposed to returning to smoking cigarettes, because we know those are bad too. And if your patient is unable to stop vaping, we recommend that you monitor for symptom development and be in close contact with healthcare, and especially avoid unregulated or modified products that are most commonly associated with this disease. All right, that was a bit of a rabbit hole. I think we're going to change gears here. So your patient couldn't stop vaping, and now they have EVALI. What do you do? With that, I'd like to welcome up Dr. Stanton, who's going to talk about the clinical management of EVALI.
Thank you, Dr. Feldman. Okay, so I'm going to return to Dan. You remember him from the beginning of the presentation. He was a vape user with one-day history of nausea, cough, and fever. So the question remains is, does Dan have EVALI? Well, the CDC has multiple great resources on their website, including this flow chart on assessment and management of these patients, and we're going to walk through this, applying it to Dan. First, if you do have a vaping patient, there's just specific questions to ask, and there's a full list of questions available on the CDC with details in it around these patients. But I'm going to summarize it with these questions. What products or devices does the patient use? What substance does the patient use or believe to be using, since they could be using nicotine, THC, CBD, or just flavoring? Where did they get the device from, and where did they get the substance from? Was it from a perhaps legitimate source, or was it from a friend, relative, or the dark web? When did they use it last, keeping in mind that the CDC case definition is vaping within the last 90 days? And then, is the product available for testing? And currently, the FDA is only accepting products that are paired with a BAL. There's a product sampling submission information pathway that's available on the FDA's website. Keeping in mind the samples paired with a BAL do not need to be submitted at the same time. So applying this to Dan, asking him these questions, Dan states, I use a blue e-cigarette regularly, as well as a pen my brother gave me called TKO and a CBD pod mod only after exercising. I also have a Juul and an e-hookah I modded with flavoring. This illustrates that these patients may have multiple different devices and multiple different substances that they are using at a time. He last used any product this morning, and he only has the nicotine product available for testing if needed. Working down the flow chart, if your patient does vape, it's important to get a good history of their present illness, including a focused history and physical exam and vital signs. Also keeping in mind that this is a diagnosis of exclusion and the usual suspects should still be ruled out, such as influenzas and other respiratory infection. Going back to Dan, in summary, he's a 23-year-old vape user with cough and fever for 1 day. His physical exam is benign. His lungs are clear. His vital signs are normal with a slightly elevated temperature. His chest x-ray shows a retrocardiac infiltrate, and his influenza testing sent was negative. So does Dan need to be admitted to the hospital, or can he go home? All patients with a normal oxygen saturation, no respiratory distress, have no comorbidities or their comorbidities are controlled, they have reliable access to care and are able to follow up within 2 days, do not need to be admitted. Applying this to Dan, he's discharged with antibiotics for his community-acquired pneumonia. He's instructed to stop all vape use and he's offered counseling for his nicotine use disorder. He's screened for and giving an influenza vaccine, and he's instructed to follow up in 48 hours. But then, Dan calls the clinic back 24 hours later, and he reports worsening cough and dyspnea. So he's instructed to go to the emergency room. If your patient needs admission to the hospital, a usual infectious disease workup should be performed, including influenza, respiratory viruses, and possibly a sputum culture. Imaging should include a chest x-ray, but if that's normal and EVALI is highly suspected, a CT of their chest can be considered. Urine toxicology is noted on the CDC pathway. However, we feel that there's some questionable utility in this, as it's unlikely to acutely change management. As well as many of the available urine toxicology analysis are done by immunoassay, which may cause false positives or false negatives. Also, it's hard to tell when what dose a patient's using, what route they're exposed, how they're exposed, and the dose they have of what substance they're exposed to just using urine toxicology. For example, a patient may be just vaping CBD, which has, or a patient may be vaping just nicotine or flavoring, but they may be using CBD, which may have a small amount of THC in for a different reason, via the oral route, for example, and this may cause a positive THC screen on urine toxicology, but their vaping actually doesn't have any THC in it. Other management should include, obviously, stopping the insult with offering services to stop using instead of just telling patients to stop using, which can include nicotine replacement therapy and addiction counseling. Treatment should include empiric antimicrobials and antivirals until infection is ruled out. You may see these patients receive oxygen and bronchodilators and corticosteroids as well, which I'll discuss on the next slide. These patients can have intensive consulting services involved with their care, including medical toxicology, pulmonology, critical care, infectious disease, or psychiatry and addiction, with other consulting services involved depending on concomitant comorbidities. As far as corticosteroids go for EVALI patients, there's really no robust comparative data, but the majority of patients do receive steroids. There is some concern that steroids may worsen infections outpatient, and this should be considered as a risk-benefit discussion based on their comorbid conditions. And it is reasonable to wait till other causes are ruled out before starting steroids outpatient. They have been used more frequently in older patients and those with cardiac and pulmonary disease, including asthma, COPD, interstitial lung disease, and pulmonary hypertension, and the majority of inpatients do receive steroids. The dosing varies, and it's reasonable to give these patients a milligram per kilogram methylprednisolone or equivalent daily, and there have been reports up to 500 milligrams of methylprednisolone have been used on these patients. They're frequently given more than a week's time. There was a small analysis on rehospitalized patients, and they found no difference in the percent discharged EVALI patients compared with those that were rehospitalized, died, or were neither rehospitalized or died. The CDC states there might be a small benefit giving patients steroids in EVALI injury, especially considering other comorbid conditions. So going back to Dan, on hospital day 1, he's tachycardic, hypertensive, and tachypnic. He's requiring 10 liters per minute of oxygen to maintain a saturation of 94%, and he has a fever of 101.5. He's cyanotic on physical exam, including coarse lung sounds. He's on high-flow nasal oxygen. He's receiving nebulized albuterol and epitropium, and he's eventually intubated for impending respiratory failure. CT of his chest shows numerous ground glass opacities. His respiratory viral panel is negative. His BAL is sent for culture in leukocytosis and his other labs. The poison center is contacted for medical toxicology consult, and pulmonary, rheumatology, and infectious disease are also consulted. On hospital day 2, his workup for infection and rheumatic disease is negative. He started on methylprednisolone 40 milligrams every 12 hours. As BAL and available vaping products are sent to the CDC. On hospital day 3, his oxygenation slowly improved, his sputum cultures returned negative, his antibiotics were discontinued, and he was extubated the following day. A usual hospital course for these patients should be considerations of airway management, intensive care unit considerations, seeing that a third of these patients were admitted to the ICU. Systemic glucocorticoids may be seen. The length of stay varies from days to weeks to possibly months, and these patients have multiple interdisciplinary care teams involved with their care. So if your patient's hospitalized, when do you know it's time to discharge? Well, when they have normal vitals, their symptoms are resolved, their comorbidities are controlled, they have reliable access to care and a good social support network, and they have reliable follow-up, ideally within 2 days. The CDC has an EVALI discharge readiness checklist available that's broken down into clinical stability, ensuring initial follow-up, ensuring appropriate outpatient follow-up with consulting services, optimizing outpatient medication use, and I would like to highlight that they also mention complete discharge medication counseling between an inpatient pharmacist and the patient. They should also have social care workforce involved, as well as optimizing cessation support. The reason this is important was because there was an analysis of 1,139 patients, and 31 of those patients were rehospitalized with a median time of 4 days from discharge to rehospitalization. Including in that cohort, 7 deaths after discharge were reported, and all 7 of these patients were admitted to an ICU on their previous hospitalization, with a median time of 3 days from discharge to death. So it's important to run through the discharge readiness checklist to know patients are secure for discharge. The characteristics of rehospitalized patients or the patients that died were older. They had multiple comorbidities, including diabetes, cardiac histories, and pulmonary histories. And there was also a possibility that re-exposure led to recurrent disease. So applying the discharge readiness checklist to Dan on hospital day 5, his vitals are normal with ambulation. Social work met with him to perform a substance use screen. He's discharged on a home oral steroid, and had follow-up in 48 hours with a primary care physician, a pulmonologist in 2 weeks, and addiction medicine in 2 days for his nicotine use disorder. Following up 3,000 days later with Dan, he thanked everyone that was involved with his care, especially the pharmacy staff. He traded his vaping devices for a diploma, got his PhD, and became a lead vaping researcher, eventually winning the Nobel Prize in Medicine. The CDC has multiple resources available, including guidance for healthcare professionals, surveillance, reporting, treatment considerations and recommendations, and additional testing. We have the website available on the slide. It's also easy enough to Google CDC EVALI. So in closing, it's very important to identify these patients and getting focused histories around patients' vaping use and anything else they know around what they think that they're vaping. Supportive care is really the mainstay of treatment, and the meticulous follow-up is important just due to the alarming number of rehospitalizations and death. We think it's reasonable to include poison centers and public health departments in the management and surveillance of these patients. We also feel vaping is going to continue regardless of the regulations at the state and federal level. And there's many questions that remain that we may or may not know answers to at all, if ever. Most importantly, to avoid complications from vaping and all other substances, there's no quality assurance on the streets. So we advise everybody to don't do drugs. This is our contact information if you have any questions around this, including the National Poison Help number for other questions and concerns. Our references are available here, and we will attempt to answer any questions that anyone has.
Thank you so much. This is Gretchen Brummel again. I'd encourage you to enter any questions you have for our speakers today in the lower right-hand corner in the Q&A box. And we'll start to see those questions rolling in. So first question, you talked about the fact that the average age of an EVALI patient tends to be younger. However, these products have been marketed as a way to quit tobacco smoking, so they're also potentially attractive to older patients. Is there a potential risk to miss the diagnosis in older patients due to this bias, and how do we avoid this?
Well, there's definitely a potential to miss the diagnosis or to not be classified as EVALI because the older patients are likely going to have other comorbidities like cardiac disease, which could be contributing to their symptoms. So the key is, I guess, it can't be diagnosed until it's thought of. So you have to just keep the idea that EVALI is a possible etiology of their symptoms. So with the way it's defined right now, it's a diagnosis of exclusion. So in that sense, if I have an older patient with heart failure who comes in with shortness of breath and they have, pulmonary edema and X-ray, you're probably going to say that's heart failure. And in truth, they wouldn't qualify as a confirmed case. But if the team thinks that it's maybe a severe case and maybe it's exacerbated by their vaping, they could, I guess, report it as a probable case. It is certainly something that would be difficult to avoid. And if you look at the deaths, the median age is much higher, so they are also the highest risk. We really don't know, and there was a statement made by the CDC regarding influenza. Basically, once influenza season is out, it's going to be impossible to get confirmed EVALI cases because you could have influenza and vitamin E acetate or some toxicant-induced lung injury, but you wouldn't qualify as a confirmed case because you have a positive influenza test. And we don't know if having lung injury from this makes you more prone to getting infection or have worse outcomes from that infection. So I think the key is to just keep it in mind. It doesn't necessarily change your supportive cares, but you have to think it to be able to put it on your differential.
Perfect, thank you. The next question is there any evidence or recommendation to favor parenteral corticosteroid over enteral?
There's no evidence that I found on favoring one over the other. I know patients were given enteral steroids. They were also given parenteral, but yeah, there's nothing that I found on one being better. So giving it, an equivalent, if you're going to use steroids, giving an equivalent dose of whichever one of around a mg per kg of methylprednisolone is reasonable.
Thank you. I'll just pause for a moment and see if there's any other questions. Please enter them in the Q&A box in the lower right-hand corner of your screen. David, I'll ask you to confirm if there are any other questions. Oh, actually, there's one coming through. Okay. How soon would you recommend that a treating team or ED contact the PCC if EVALI is suspected? Wait until other diagnoses are ruled out, or are leaning in that direction, or notify sooner in the course?
I would say right away, even if it is a diagnosis of exclusion, the poison center, so these patients transition in care at times. An ED provider might see a patient, they've got flu-like symptoms, they send a flu swab, and maybe if we're lucky, you get a sputum culture. But they're basically a pneumonia or flu patient until those are ruled out, in which case we could say, okay, maybe it's EVALI. So having the poison center checking in with the inpatient admitting team can help confirm or help keep that in the back of their mind, as well as be a resource for testing and different treatments that have gone on. It definitely doesn't hurt to advise them or to get them involved up front and right away.
I think the other aspect of the getting poison center involved is, these patients ideally will leave the hospital, and if on follow-up, it's much easier on follow-up if who's a pulmonologist or primary care physician who's ever seeing the patient has questions or concerns, they can call that same regional poison center back, and the poison center will already, understand what's going on with what happened with the patient, and hopefully it'll give us a little more direction as far as assisting with other recommendations if needed.
Perfect, thank you. A couple more questions rolling in. Are you aware of any correlation between the concentration or amount of THC and EVALI risk, or is it just that any THC is a higher risk?
Nothing that I've seen regarding concentration. It's also difficult because time from exposure to time of symptom development and time to actual encountering healthcare are widely variable. So they could have been using something, developed symptoms over a few days, and then showed up to healthcare and already have symptoms and possible lung injury at that point, in which case their level would be significantly low. So even that would be really hard to correlate. All we do know is that THC has shown up positive, and it's the THC products that also show up positive with vitamin E acetate. But no strength correlation in terms of like a level for severity of disease.
Okay. Are you aware of any information about risk of secondhand vape exposure?
That's a great question.
Yeah.
I'm not familiar with that.
I am not. I mean, obviously the concentrations in the user's lungs are much higher, but if you are in there's really a lot of unknown with that. I don't have a lot that I can comment on.
Okay, thank you. see. Okay, so this is more of a recovery question. So does EVALI completely resolve for those who do get better, or are there long-term complications, or is it too soon to tell? And that kind of ties into another question on here about the physical damage to the lungs as well, or is it just symptomatic?
In terms of the physical damage, there is. So there's some they've looked at the actual types of injury under a microscope, and we do see damage, which leads to symptom development. I think it might be too early to honestly say with assurance that everything is okay, but the CDC in their Morbidity and Mortality Weekly puts out characteristics of these patients, and they also have, so there's a few reports in there which I would say, if you're curious, are a good reference. So they talk about the clinical course, how many people are discharged, and they also have a whole series on just people who were treated outpatient alone to see if they get better. People do relapse, and we do have recurrence of disease, but they recommend pulmonary follow-up within 2 to 4 weeks for additional pulmonary function tests and resolution of like X-ray or X-ray findings. But I don't have the statistics on how many of those are completely normal afterwards.
Yeah, ideally, these patients are going to be continued to get followed, and maybe we'll have better answers in a year or two from now.
Well, our last question is actually a comment, which is outstanding speakers, very knowledgeable. Thank you very much. And I will just echo that sentiment. And thank you all for participating in today's call, all of you who dialed in today, as well as our speakers. Thank you all for joining us, and we look forward to seeing you at next month's CE. And with that, we will wrap up today's talk.
Thanks, everybody.
Thank you.